All right, good afternoon, everybody. I would like to welcome you to our joint workshop with the hospitals to discuss our bed delays. Today is May the 9th, 2016, and it's just a little after 2 p.m. If you could all stand with me for the Pledge of Allegiance. Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right, Madam Clerk, can we have roll call?
Sure. Chairman Bryant?
Here.
Vice Chairman Zalek? Commissioner Moore?
Here.
Commissioner McLean?
Here.
Commissioner Arnett?
Here.
And Commissioner Zalek, unfortunately, will not be able to join us today. I'd also like to, if we can have all of our participants also introduce yourself and what entity you represent. That would be appreciated.
Bob Moore, CEO at Monroe Regional.
Randy McVeigh, CEO of Ocala Health.
Ginger Carroll, CEO, West Marion.
Rodney Masco, Division Chief, Marion County Fire.
Paul Neville, Fire Chief, Marion County Fire Rescue.
Okay, and I believe I see our medical director sitting there. Did we want to have a spot for him at the table as well?
We can. We have a chair empty.
Would you like to come take the clerk's seat? Sure. Thank you.
Tell me where that's.
Right there. And then you can just introduce yourself as well.
Sure. Frank Fraunfelter.
Oh, wait till you get in the, yeah, we are recording, so.
Frank Fraunfelter, Medical Director for Marion County Fire Rescue and Ocala Fire Rescue.
All right. All right, with that, I believe that we are going to have our presentation today by Chief Nevels, our Marion County Fire Rescue Fire Chief.
Okay, good afternoon, Commissioners. There we go. Okay, first of all, we have talked about this at some length in one of the last commission meetings, so I will still peruse some of this information for you, and please stop me if you have any questions if I speak too fast or anything like that. One of the things we did just start tracking the stats back in January of 2015 on bed delays, and what you have before you is the instance that we have tracked since then. You can see that it has continued to rise. Typically, as you may well know, that the bed delay problem is typically worse in the winter and flu months, and typically when folks are down, transient or snowbird folks are down. You will also notice that it spiked tremendously this past spring, and but however, you see the typical trend that we run into there in April, where it dropped off fast, and typically that is due to the lack of flu season and lack of snowbirds and just lack of heavy call load. Real quick,
Chief,
yes.
do we
yes,
have
ma'am.
a number to date for May?
I do not have a number for May to date. It looks like just roughly it's staying on trend probably with April.
Okay, thank you.
Sure.
Commissioner Arnett?
How much of a delay before it gets on this list?
How much of a delay? Ronnie, is that the
Anything greater than 20 minutes.
20 minutes?
Okay. Thank you.
Okay. As far as the timeline, as we had talked before, around 2004, it started to become a problem, and everybody worked together, the hospitals, the EMS, medical director, to work on the throughput and to solve some of those issues and crises, and it got much better through those years. We began to see a problem, a major problem, probably winter of 2014, fall and winter, and that prompted us to meet as for our senior county staff with the CEOs and Dr. Fraunfelter back in March of 2015. From there, a bed delay work group was formed with the hospitals and our staff, senior staff, to discuss these issues. And of course, that began in September of 2015. Also in the same month, Chairman McLean, then Chairman McLean, and I met with the hospital CEOs to let them know and their senior staff that this was continuing to be a significant issue. 2016, in 2016, of course, Chairman Bryant met with us and the hospital executives in February to discuss the issue, and it was decided at that point to go ahead and add the senior leadership at the executive levels to that work group. There were multiple meetings in March with that, and quite a few, and I'll get to slides, quite a few initiatives have come up since then as far as the work group working together to try to alleviate some of the experiences and the delays that we've all experienced together between the hospitals and our team as well. One of the things also was there was a workshop that was requested at one of the last commission meetings, and that's of course where we are now at this point. Some actions taken thus far. Quite a few initiatives were put together by the working group, and there's quite a list there. Some of these things were put into place immediately. Some of these things obviously take a while to get to move things around and the logistics speaking. And certainly, I believe that the hospital leadership will speak to some of this later. I don't want to speak for them on anything, but we have a list of those things that were put together by the group. And there were some things that we also did from Marion County Fire Rescue standpoint as far as staffing a couple additional ambulances during the day, during peak hours when we could get away with that. That is, when we had staff that we could put on overtime on those trucks. Some possible options that we had looked at, and this is from the Marion County Fire Rescue standpoint, was that the facilities make changes and accept EMS patients in a timely manner, implementation of the possible bed delay fee, and that being to present an ordinance to the county commission for approval. Notification to ACA, that is the agency responsible for these, for this type of thing. And that is something that we have not discussed with the work group. We have not considered calling to make that phone call. However, that is something that some
Chief.
other agencies have done.
Commissioner Moore?
Quick question.
Yes.
That says significant delays. What's the difference between the average bed delay and a significant delay?
Okay, well,
Or
for
are
us,
they
it's
one and the
over
same?
20 minutes. And as far as, I mean, that's a bed
Because to me,
delay.
a significant is 20 minutes, but obviously, since that's a different wording,
No,
obviously
that's
there
a,
must
that's
be
a good
different
question. It depends on how you
definition.
define it, and I'd like to pass that to our EMS chief, Rodney Moscow.
ACA defines it really as a delay is a delay. They're not gonna qualify it as significant or not. So part of that thought process from agencies that have implemented that particular action really has been more related around repeated delays or those of a longer nature. You know, the majority of EMS agencies try to work with the hospitals like we've been doing with the hospitals, and they've been working with us to try to take care of, you know, delays. But if they're sitting on a wall,
Right.
you know,
And
there's supposed to be a
how-
timely transfer of care.
On average, because I know we've mentioned anything over 20 minutes, but on average, how much are the average bed delays? Because I've heard from fire rescue gentlemen that they've been there for hours, which
We've
I don't know
had
if
as
that's normal.
we've had as high as 6-hour bed delays that our crews are standing on a wall for 6 hours. This particular calendar year, we've had way more of those than typical. So it's not uncommon to have that happen very regularly. Probably the greater number of them, when you look at the statistics, are the 20 to 30 minute, 30 to 60 minute. But there's still quite a few that are over the 1 hour mark and hitting 3, 4, and 5, 6 hours.
I think an important piece of that as well, there's times when you get 6 or 7 ambulances simultaneously in a facility, and to be able to absorb all those patients in a timely manner becomes a challenge for the emergency departments, no matter where they are, right? And so there are times when a lower acuity patient is going to be taken in a queue, and so we're going to take the higher acuity, the heart attacks and the stroke patients or the trauma patients,
Right. But
and absorb them quicker.
In my opinion, the hospital should check them in, and that should be on the hospital, not on our fire rescue. Just
Sure, but it's still a coordination of that care.
correct, which is why we're here today. So.
Okay, go ahead, Chief Nevels. You want to
Okay.
finish up?
Thank you. Okay, one of the other options, and this has happened some other places, we are quite frankly, that doesn't seem to be the best option with us as far as patient care, is the transfer of the patient to a cot within the ED. Facilities also providing paramedics to accept patients. That means that the facilities, hospitals would actually put people on their staff, a paramedical person that operates under their guidance and direction that would take that person from us so we can get our units back in service. Another option was that we provide those paramedics, that we hire put those people on overtime or whatnot and accept those patients and leave our paramedics there at the facilities and then bill the facility for that. And/or one of the things was just developing a contingency matrix that we would put together during peak times, and that's something that still has not even been sat down and gone over. But I mean, if we continue, say next year, next fall, next winter, and we still find ourselves in where we have multiple bed delays like it was this past year, that we have to put something in place that has to do with our guidelines, with our dispatch, public safety communications, and the hospitals working together, but something that we can put in place that we only take a certain priority call for that time period when we get to that level of EMS units transports.
Thank you, Chief.
Yes, ma'am.
Ronnie, I do have a question. Now, I know that we implemented some different things in April and May, and I know that, you know, we're all trying to work on this together, and I appreciate the steps that have been taken. So within your numbers, do you have a breakdown of, I know you have a breakdown of the bed delays, but then do you have a breakdown of the time? How many were 22 an hour? How many were an hour to 2 hour? Just for April, and I wish we had to-date May numbers, because I'd like to see what progress we've made with what we have implemented.
We don't track it specifically. We track it 20 to 30, 31 to 60, and
However you
greater
track
than
it,
60.
however you track it.
So looking at the April numbers specifically for that, for all facilities,
We've got 714 bed delays.
so of that, that one's time.
Ginger, y'all have them? Bob?
We track it for the HCA facilities, Chairman Bryant, we track it starting from minute 1 forward, and so we can give you by month.
Do you have them with you, though?
We do.
Okay, all right. So let's look at, well, Rodney, if you have them, then,
Yeah, so for April, we had 309 delays that were 20 to 30 minutes,
okay,
238 that were 31 to 60 minutes,
okay.
and 167 that were greater than 60 minutes.
Okay, so greater than 60 minutes, is that 2 hours, 3 hours, 4 hours? Did you not break that
We
down?
don't break it down beyond that. I mean, we can, but I don't have that with me. We'd have to run that separately.
Okay. Does anybody have those numbers?
I've got Monroe's to compare.
Okay.
So this is, again, in March, or you want April only?
Well, I
Or you
think
want the
April is where, I mean, we can look at March as well, and then look at April, so that we can see, what I'm trying to find out is, are we seeing reductions in what we've put in place?
Well, and let me,
And I know we're seeing a reduction because of our population move as well.
well, actually, ours is pretty flat on visits and EMS calls, so we're comparing apples to apples, March to April. Out of the 309 that the chief just said, in April, we had 92 in the 20 to 30 minute range
Okay.
at Monroe. Out of the 238, we had 54 in the 31 to 60, and of the 167, 61 plus, we had 47. But from March to April at Monroe, we had a 53% reduction in bed delays, going from 407 in March to 193 in April.
And Commissioner, the greatest reduction from March to April actually fell within the 61-minute plus. We went from 563 to 167, so that's where the greatest decrease of bed delays was in the lengthier ones.
That's very good.
And that's what our data shows.
Okay. And now your numbers are gonna be different than,
They'll be a little bit different just because of the way we're tracking the internal numbers, but we saw about a 50+% reduction in wall times on average in April from the month of March and February.
okay. So can you give me numbers for March and April, and then can you also come back and give me your numbers for April? Because you gave me March.
No, I gave you April, actually.
Oh, that was April? Okay, so can,
I can give you March.
it's okay. Can you give me April numbers?
Yeah, let me add them up real quick.
Okay, thanks.
So at Ocala Regional, what I'm showing for, and I'll just use delays over 30 minutes, we had 485 delays over 30 minutes in March and 233 in April, and that's the Ocala Regional campus.
Okay. Do you have, that's over 30 minutes?
Yes.
You don't have them broke down to the 31 to 60 and then 60 plus?
Well, it's 31 from 31 on.
On
is the-
up,
the
okay.
total.
Commissioner, on Ocala Regional, I had that as 117 for 31 to 60
Okay,
and 289, which should put us pretty close to the same number total. 289 that were greater than 60.
okay.
And then for April, they dropped down to 68. So again, a huge decrease in in that longer timeframes.
All right, so there were 68 over 60 minutes in April. How many 30 to 60 in April?
In April for Ocala Regional, I had 94.
Okay, not the 117.
Sorry.
So 94, it's okay, 68. And then the 20 minutes, 20 to 30?
For Ocala Regional, I had down for 90. 90.
90, thank you. Okay. So, obviously, our population moving, and then hopefully some of the things that we've put into place have helped reduce some of our numbers. Now, I know that you've hired paramedics.
Paramedics and RNs, we've hired 30 RNs that'll be coming off of orientation this month. And today, we had the largest RN class we've had, 28 in that. It's not just an ER issue, because it's upstairs.
It's systemic.
And we had 4 ER RNs today and 3 paramedics, but we've gone back to team nursing where we're pairing an aide, a paramedic, and a nurse, which allows for better flow. So ours has been a staffing problem. It hasn't been a capacity problem. We've got the capacity. We're now fixing the staffing.
Okay. For you, moving forward into the fall, when we get into where our population starts, our snowbirds come back, we've got more population, flu season hits, do you think the capacity that you have and the staffing levels that you're going to be at, with that, do you think that you're going to be able to keep your numbers down?
Yes, and here's part of the reason. As I look at it, the last 2 years, we had over 280 RN vacancies. We're down now to about 60, and our normal is 40 to 50, just of normal attrition. So assuming that we're able to keep the staff that we're training, we're going to be set for September.
And are you still hiring more?
We're still hiring more. Like I said, we had 28 RNs today in orientation, and we've got almost that many starting 2 weeks from today in orientation. Now, they're anywhere from 6 to 12 weeks coming off that orientation, depending if they're a critical care nurse or a med surgeon nurse. But by mid to the end of the summer, they're going to be productive employees.
Okay. And for the benefit of the rest of the board that hasn't had the opportunity to sit in on the meetings that we've had, Randy and Ginger, would y'all like to let them know where you are and where you have seen your issues and
Sure.
why this has happened?
Sure. Part of the issues we've seen at both Ocala Regional and West Marion is capacity. As an example, today we're setting over capacity at our campuses again today, continues into to May. We do several things, and I'll just go down through a few of the items with the HCA facilities, some of which Bob, I'm sure, is doing at Monroe as well. We immediately recept the patients in when the EMS trucks arrive to do a medical assessment to try to determine what's the best placement for those patients, and that tries to help us make a quick decision on what we can do with the patients. At our campuses today, we have 42 emergency department rooms. We have the ability and staffed up all winter long to an additional 18 places to house emergency department patients that's coming into the system at any time during the day or night. We also have what we call admission units at both campuses. At West Marion, that's an additional 4 beds that we have somewhere in the building where we can move patients out of the emergency department At Ocala Regional, that number can go from 10 to 18 additional beds that we can place patients in out of the emergency department or from other parts of the operation. And those will continue to be staffed as we need them through the summer and into next fall. One of the other items that we have within HCA is we'll be opening a freestanding emergency department operation in the fourth quarter of 2016. We're targeting the month of October for that opening. It'll be in the southern part of Marion County, where we receive between 10 and 12% of our emergency room visits today at either West Marion or Ocala Regional. We think that should pull about 8,000 to 10,000 emergency room visits from the two hospitals when that entity opens up in October.
8,000 to 10,000 per month?
Per year.
Per year,
Yep.
okay.
That's our assessment from the first year of operation on looking at that entity, and we believe, and why we're timing it for quarter four is going into the winter months again. We also will be breaking ground a little further into the future at West Marion, another expansion at that campus. As you may recall, Chairman, in our discussions, we added 46 beds, inpatient beds, at Ocala Regional and West Marion over the last 12 months. We'll break ground to add an additional 44 beds at West Marion. Those beds probably won't come online until late 2017 or early 2018, but we're recognizing the need for the additional beds, as well as at that campus expanding the emergency department.
You
for
just
more
want to keep
capacity.
Ginger busy, don't you?
Exactly. And in the ORs as well. So we're trying to continue to add resources and facilities as we seem fit for what we believe will be continuing in the future.
Okay, commissioners, any questions?
So we focus a lot on the ED, so what happens once that, how are both of you situated for beds once you move them out of the ED?
Well, that's when I was talking about the nurses we've hired. That's been our biggest challenge. I mean, Dr. Fraunfelter will tell you, it hasn't really been the ED. It's been getting those patients out of the ED once they're admitted to the floors, because we had so many vacancies. And that's helped considerably. I mean, there's a couple other points that I'll point out. We changed our triage process, which has allowed us to expedite care better, where we got a provider right there triaging that patient. We also added something you've probably seen in the news called ER Express, and we just had a 191% increase in the number of pre-scheduled ER visits. You know, if you want to come in at 9 o'clock in the morning or 2 o'clock in the morning, we can get you in and out in usually 30 to 45 minutes. So we're finding some of the people will go online and schedule, come in so they're not waiting and bottlenecking the ER in the busiest times. And that was almost 200 visits.
Okay, so I got a question about that. They shouldn't be there anyway.
There's part of the problem. 34% of the ER visits, as we know, and I think EMS can actually show that they shouldn't be there. But remember, an emergency is determined by the individual.
Exactly.
So when they come in, we have to treat them.
So can I ask this
I
question?
can wait an hour, I just can't wait
Right.
2 hours.
Right.
So just, I guess, let me ask this question. When you have somebody calling in the morning to schedule their ER visit to 11 o'clock at night, can you legally suggest they go somewhere else? I mean, because, I mean, I'm just,
You can ask the question, have you called your primary care physician? Most of them are going to tell you they don't have one. That's why they're calling you.
okay,
And unfortunately, in our county, we're underserved by primary care.
okay.
Getting in is difficult. Once they hit our campus, we have to do a medical screening and clear them for EMTALA.
I understand, I mean, but can you guide them to other, if they haven't called their primary physician, can you say, well, you know, you could probably get into express care or, I mean, I'm just asking that question.
Some of them still don't have the financial wherewithal to go somewhere
And that's
else.
part of the problem.
That's part of the problem
'Cause
there.
The ER is open to anyone and everyone, no matter what their ability to pay.
Okay.
But everybody's supposed to be covered under Obamacare, remember? Oh, sorry.
Okay. I'm
And I
sorry to
think the
interrupt,
oth-
please
the
go
other
ahead.
thing, to answer, you know, the upstairs issue, we've also started to bring at Monroe LPNs back into the picture, just like we did with paramedics down in the ER and team nursing there. We're doing the same thing on the floors because we don't have enough RNs to fill our needs.
Right.
Our hospitals. So we're bringing LPNs back in, teaming up then patient care tech, an LPN, and RN. And that's helping to solve some of the staffing issues as well. There's 63,000 RN vacancies in the state of Florida right now, and it's only going to get worse.
Which is why we need to have another discussion when we're done with this discussion at the end of the meeting, before y'all leave, if you don't mind. All right.
Randy, what about you guys? How are you guys as far as once you assess them, and do you have enough beds and that kind of stuff?
Again, Commissioner McLean, part of our issues in the HCA facilities are capacity issues with the number of beds, mostly throughout all of this past winter and most of 2015, and it's continuing into 2016. Our beds are usually full throughout the hospital, so throughput's extremely important to us. So we do things such as between the two campuses, if we have openings in one of the two campuses, we'll transfer patients between the two campuses if we have some room to do that. During the winter, when it was really high volumes coming into the building, we canceled elective surgeries multiple times through the winters and postponed surgeries into another day during the week when the volumes are a little bit less, as you watch the trend lines week to week and Mondays through Sundays. And we also attempted to transfer patients outside of the county to sister facilities, either in Citrus or Alachua County, if we could get the family members and the patients to agree to do that in order to free up some capacity in the buildings. And frankly, again, that's another reason why we expanded, as we did in 2015, and have another expansion for West Marion funded and groundbreaking later this year. And quite frankly, I'm working on another expansion for Ocala Regional, hopefully to announce that later this year.
There you go, Bob.
And I think, as you all know, we've got expansion plans also that by the end of the year we'll break ground on the ER expansion. That'll give us additional beds in the ED. Again, the difference between what Randy's problem is at Ocala Regional and Monroe's problem, ours has been staffing. We've got plenty of capacity. We have 421 beds. But on most given days, we couldn't put more than 350 to bed. So as we fix the staffing, the throughput improves, and everything you can see just in a couple months, the metrics, the average on the wall time has decreased almost in half, and 52% drop in bed delays. And as we continue to work on these changes, we'll get this issue solved.
Randy, so yours is capacity. You don't have any staffing issues?
I wouldn't say we don't have any staffing issues, Commissioner Bryant, but we aggressively, as Bob's mentioned, we're recruiting all of the time, every month. We have classes of staff coming in every month, sometimes multiple times a month. And we have one of the lower turnover rates within HCA in the state of Florida for RNs and total staff, and we work hard to maintain that type of a ratio. But there's always going to be open positions. You just constantly are recruiting for that.
Okay. So an option that we talked about the last time that we met was, hiring the paramedics to be stationed at both hospitals. Is that something that you've been able to take into consideration a little more so that we could possibly, we can get our guys in and out? Because I think one of the biggest problems, you said, I understand that it's capacity, but as we've said before, they're still standing on your wall. They're there regardless. And so the thought process that I had was, what is the difference if it's our guys standing there on that wall with the ambulance parked out that is out of service, or if it's either somebody that we're hiring to be stationed there, or if it's somebody that you're hiring to be stationed there. Preferably, for me, it would be somebody that you've hired that can check that patient or take over that patient. Has there been any more thought process into that? Because we all know that in a few months, it's going to ramp back up and we're going to be facing this problem again. And I think we all want to be able to find a way that is the most economical for all of us and gets our guys back out there. That's the main goal. Get them out there as quickly as they can so that we have enough ambulances to cover the county. So has there been any thought into that?
Well, that's when I said, hiring the paramedics. And we actually, I think it was just the 5th of May when we put them into service. So we're just now starting to see the benefit of that. The other thing that I didn't mention earlier, and I believe if you talk to the EMS crews, they're going to tell you it's helped. When they call in and they're en route, we're assigning a bed. So they come right in and they can offload. And that's what's cut the delays significantly. Again, when you got 40 bays full and no place to go with patients, you're gonna have delays, but hopefully we're minimizing it. But we've hired those paramedics, and that's gonna help considerably.
Is the end game with those paramedics so that our guys can hand them over to those paramedics and leave? Is that the end game?
Yes, but the best is to hand it over to that RN, the paramedic.
Oh,
and the tech.
absolutely. But
And when we've got the full staff, that's the best way to do it.
that's absolutely the best
We're trying
way.
to get them in and out as quickly as we can, and, I mean, if you look at the numbers, it's working. But I think, as I said the last meeting, we need a little more time. You know, it's only been about 30 days since we've implemented a lot of these changes, and we're already seeing a dramatic impact as a result.
And I think that this board would be willing to do that, but we need to know that when our numbers start ramping back up, the end game is that you're gonna have somebody who can take that patient and our guys can go. I mean, that's where we need to go, without having to implement some of the other stuff that we've talked about. That's,
Commissioner Bryan, at Ocala Health, both locations, we've had paramedics employed for several years now. We have had them employed on what we call a PRN basis. We have converted many of those positions just recently to full-time positions,
Okay.
which will allow them to be there, you know, on a regular schedule rather than us call them in, which is a little less predictable than in the past. So that's really been something that we've made a conversion to in the last couple of months. So we're in the process of hiring full-time medics for both locations. We do have openings and we are interviewing.
good. And the last time that we met, I know that we discussed, your on-call.
Mhm.
And did we get those issues worked out?
Mhm.
So that that transition is smoother from whoever would make that phone call to your, ED director?
Or supervisor.
Yeah,
whoever's on.
supervisor, okay.
We will do that right now, we're in pretty good shape, as far as the staffing goes. It's really the winter months when we
Right.
don't know when
Right.
we're gonna need that extra person, additional help. So, we will have that in place, certainly when we need to ramp back up. I think we, particularly at West Marion, are gonna be challenged one more season with space, just because, and then we're gonna throw construction on top of that. So, I think this winter, we would be remiss if we didn't say that we're probably gonna have another difficult, winter out west, just because of the construction. It gets in the way
Mhm.
somewhat. So,
And-
we'll do the best we can, and, but I think it'll be challenging one more year.
And again, that's one of the reasons why it's critical that our freestanding ED opens in
Correct.
October. I mean, that's part of our plan strategically to be able to alleviate some of what we saw this past winter, as well as deal with some of the construction issues we believe we'll have at West Marion. But again, we fluctuate from 42 emergency department beds up to 60 at any time, based upon what Ginger just mentioned with paramedic coverage, as well as RNs and techs throughout both of our buildings in order to receive as many patients as we can.
Okay. Commissioners? Any questions? Okay, so I think that some of the things that we need to talk about was, we had talked about putting the ordinance in place for the charges. In some of my discussions with our CEOs of the hospitals, they have asked that we hold off and that we give some of the things that we've implemented an opportunity to work. And so what I need from our board is to know, and then they also asked that, if we were going to do that, could we possibly, they felt like the time that we were putting on there to start billing, they felt was a little unreasonable. So they had asked if we could discuss if we are gonna put the ordinance in place. And I did explain that just because we put the ordinance in place didn't mean that we absolutely were gonna follow through with that. But if we were gonna put the ordinance in place, could we maybe make that time, I think they wanted 2 hours, if I remember correctly from our last meeting. I didn't know if I wanted to quite go that long, and if that was reasonable. And so I thought it was a discussion that we all needed to have together so that everyone could understand where the board wants to go. Commissioner Moore.
I've talked with people over at Shands, because my son's of course, going through chemo and going through cancer. So Shands has got a great thing, and they are affiliated with one of the 2 hospitals here. But one thing that I heard from them that Latra instituted was every 15 minutes, a $250 thing. So I asked them, well, how's your bed delays now? Amazing how they got it corrected, because it hit them in the pocketbook. It became an economic thing. I'd rather not do it this way in Marion County, because Ware-Alachua County is not what's best for Marion County. But that is the, way that Shands got their situation, and I guess all the other hospitals in Alachua got their situation corrected was when it smacked them in the pocketbook, when it affected them economically. So that is like the end game. But the main thing is we need to have our fire rescue guys out there doing what they're supposed to be doing, which is out responding to accidents, saving lives, not sitting on a wall for 3-4 hours. So I'm a little hesitant on, I'm willing to give some leeway, but I'm not willing to give a lot of leeway, if that makes sense. I'm willing to see if this works, but, in the end game, we can't have what we just had.
Commissioner Moore, I can't speak for Shands,
Right.
but I can tell you that for North Florida Regional Medical Center, it may have solved some of the bed delays for that particular organization since it's a sister facility of
Right.
ours. But as Dr. Fonfeller mentioned earlier, when you have an influx of ambulances and you have a full emergency department to begin with, you're going to have bed delays. That's not an unusual circumstance to occur in a hospital, particularly in the state of Florida during the winters. So,
Right. But they mentioned it, theirs really improved drastically. Of course, with theirs, like they have the children's emergency one side of the street, and then they have the adult emergency on the other side of the street. So they have actually 2 emergency rooms now, whereas back years ago, I think it was just 1 emergency room. So they did some things on capacity side too, which I appreciate, with my son having cancer, I appreciate that they have the children's emergency, because that way you get in and you're in when you have to be,
Well, Commissioner Moore, on that same line, we've got the freestanding ED out Timber Ridge out
Right.
at, well, on top of the world. We see over 30,000 visits out there. And just like Randy said, with their facility going south, that will help. Thank God we have those facilities,
Freestanding.
because otherwise it'd be an influx right here in town.
Well, the other was with that 34% that are there that probably should be at a walk-in clinic or something. I know like my doctor's office is affiliated with the one over here on 25th Avenue. So I go into the 25th Avenue, they pull up all my medical records at a walk-in clinic. But, we need to figure out a way to maybe encourage that, because that means 1 out of every 3 people coming through that emergency department probably should be over at that walk-in clinic. So if we could figure out a way, to encourage people to, maybe through better education, I don't know what it would be, to encourage them to go over there. And then the other, that I've heard suggestions from some people is, on our side, when there's the person that just has the sniffles and doesn't have a serious medical emergency, some counties actually give them like a transport, but give them like a taxi cab or something instead of tying up an ambulance for something that's non-medical emergency. But then that's not good on your side, because they're still tying up your emergency room for something where they should be at a walk-in clinic. So, but that's one challenge, because if you eliminated 34% of the people in that room, emergency room, that maybe could be treated elsewhere, that would free up the capacity real quick, and also take the demands off of, being understaffed real quick. So, anyway, but be interesting to see what fellow commissioners think.
Thank you. Commissioner Arnett?
Paul, from half hour to 2 hours, an hour and a half, what's it cost to have an ambulance and staff sitting at the hospital for that hour and a half?
Well, currently our standby rate is around $125 for a unit.
That's an hour?
That's an hour.
So an hour and a half would be $180. Seems to me at some point in time, and if it's reduced to a minimum, but at this point, that's coming out of the county's budget. And we need to implement something to bring that money back in, because we can't afford to keep doing that. So I think we need to implement something. And if it's not an issue, and I don't know, 2 hours I think is exorbitant. 20 minutes may be a little short, but somewhere in between there, we need to do it.
Just to highlight what you're saying, but, you're saying how much does it cost monetarily? If somebody's life, somebody is ended because that ambulance wasn't able to get back out to the accident scene, you can't place value on a human life. So, I mean, there's lives that are probably being lost as a result of this, so we gotta get this corrected. Anyway, continue, sorry. Just adding accolades to what you're saying.
No, I feel that we do have to do something. We can't afford to continue paying that much money.
Commissioner McLean?
Madam Chair, I'm gonna agree with you. I think that, I mean, we have two private sector partners here who have taken some steps to try and make some reductions. And, I think this board's always shown a propensity to try to work with our private sector partners when we can. Any private sector partners, we've had other issues besides just these kinds of things where we've tried to ensure that we're not necessarily, burdening them beyond some point that, that they can't bear. So here was what I was thinking, I guess, for me, is would you, I'm gonna make a motion. No, I'm kidding. I can't, but I would. Would you meet with the work group once a month?
Mm-hmm.
And that way you can just kind of monitor that for us, and if there's as soon as we see that there's an issue or whatever, then I think it'd be helpful. They can update you on where they're at, some of those kinds of things. You can then report back to the board, and I'm not saying that I wouldn't be in favor of doing this. I think that it's certainly, at some point in time, maybe something you have to do, but I think I'd much rather try to work with them than get into an adversarial relationship.
Right.
It's been a good relationship over the years, and so, here again, I mean, I think it's about solving a problem. It's not about whacking somebody over the head or doing those kinds of things. And so I think, and quite frankly, I've had some discussions with some folks at Shands as well, and I've been up there several times myself over the last few months. And I see lots of ambulances at Shands as well, so, and see them there for quite some time. But I think the best thing that we're trying to do here is work with our partners, try to see if we can come up with a solution. Obviously, if we can't, then you have to move beyond that. I think too that when we have our fire assessment discussion next month, I think that's June 2nd or whatever it is, that might help us have an understanding too, some of the capacity that we have or don't have, some of the things that are going on with fire rescue, and so that I think that'll help a little bit too, so, for me.
Okay.
So.
1 second, Commissioner Moore. Dr. Frauenfelder, did you have anything that you'd like to add?
Well, I think you're hitting most of the hot topics across the country and the solutions that have been looked at, right? It's not a simple solution. It's not a one-answer solution. It's a combination effect, and I think it's working with community partners. I think it's working with the fire rescue units. I know, through other medical directors that have engaged in some of these other practices, it doesn't necessarily rescue everything. You're right, at Shands there's still bed delays. It hasn't cured all ills. And so sometimes what happens is there's preferential offloading of the units that bill, while the other units that don't, other counties that don't bill, are still sat on the wall. So there's some gamesmanship involved in that. I think the staffing up for Monroe, I think the outbuildings for the other facilities is going to help tremendously. Alachua has added 2 freestanding emergency departments to their county in the past year. I think they've got 2 more slated. That's really going to be, that's what it looks like in emergency medicine, the way to help offload a lot of these walk-in patients. Because you're right, it's an access to care issue, right? And that's one of the things that works with these appointments, right? If I twist my ankle and it's swollen, I might not need to be seen acutely, but I know that I think I probably need some form of an X-ray. I call my doctor's office. They say go to the emergency department. Right? That's the unfortunate kind of lead point that a lot of practices go to. So I think access to care. We're seeing probably one of the issues of access to care in our county. When we see through the different emergency departments here, over a half of the population comes through the emergency department doors of Marion County every single year. Right? That's above average for any statistic that you see out there, and it's really about being able to care for our citizens.
Commissioner Moore?
I've got a quick question, because I know like my doctor's office is affiliated with walk-in clinic, which is affiliated with one of these two hospitals, by the way. But since my doctor's office, like, they wouldn't say go to the emergency room, they would say, hey, go to one of our walk-in clinics, either the one in Bellevue or here, and they can actually check on their thing, who's having peak hours, who's not, and they can kind of, because one time, you know, I had something where I was really sick, and they said, hey, we're booked up because it was flu season. They said, go down to Bellevue. Bellevue has an opening. So I drove down to Bellevue, walked into the walk-in clinic down in Bellevue, because my doctor was booked up for the next 3 days, and when you're sick, you don't want to get pneumonia. But, you know, they were able to do that. I'm wondering if some of these non-acute cares in the emergency room, if they could, if, say, it was just something like that where somebody has the sniffles, if the ambulance could just take them straight to the walk-in, and maybe at the hospital they could bill it as an emergency, or do something with that where they could be treated at the walk-in clinic instead of at the thing if it's non-emergency, you know, situation. Since 1 out of every 3 patients is non-emergency, could they be dropped off at a walk-in clinic that's administered by one of the 2 hospitals? Because I'm thinking both hospitals have walk-in clinics and doctors there are affiliated with them. Or is that not possible?
There are some models that have alternative care sites. There's risk affiliated with that as well when there's some underlying issues there that are underdiagnosed. I don't think that 1 out of 3 patients coming by via ambulances are the non-acute. I think there's probably more through the emergency department doors, and that number shifts to a certain extent. That's actually transported. So there's some challenges with the alternative care sites that go in with that, and some liability issues that go in with that as well. There's some big fails across the country where they've actually
tried that. Okay.
and-
Well, yeah, I was
caused
just thinking that,
problems,
you know,
so-
yeah, it wouldn't be good if somebody died, but if you could just get the person that's, you know, because some of our fire rescue guys go out to the same person's house 2, 3, 4 times in a month, and it's the same person going back, and it's just hangnail issues where it's not really life-threatening, whereas they're tying up our facilities, they're tying up the hospital facilities. If we could get them to a walk-in or something else where, okay, it's not as critical if this is tied up as, you know, the emergency.
The key to that is getting patients medical homes, right, where they have access
Right,
like you
exactly.
have. And so
Yeah,
they
access
have
is-
that ability to make a phone call and see timely care. So, and I think that's being developed, and you see that coming across the county now. And I think we're probably behind by 5 to 7 years in that sense, but I think they're actively engaged right now, and we're seeing those systems and seeing the successes.
And Commissioner, if I could just add a caveat, the laws in Florida only allow an ambulance to transport to an emergency room. So we could not legally transport to an urgent care center.
Okay,
They have to go to an actual emergency room.
okay. Well, so much for that idea.
That's a good idea. Could I get,
One moment, Mr. Minter.
I was just gonna throw in an observation that I'd had from talking with the chief and Rodney. And maybe this is already covered, but it seems to me that if it isn't covered, there's a need for some kind of protocols to be in existence that would be mutually recognized between the emergency department and our staff. It seems like, as a practical matter, one of the biggest frustrations is when you don't know what the expectation is when you get there. You know, are there any particular conflict protocols that everybody has agreed on? Are there any exceptions to protocols so that even though they're backed up, I've got a cardiac patient right now who's in really dire straits, so that between the emergency department and our paramedics and EMTs, there's a mutual understanding what we can expect under these circumstances. So in looking around the country at some of the things I've looked at, it's been pretty common for communities to, as communities like to do, appoint blue ribbon committees, and some of those after 2 or 3 years have been frustrated because they felt like they didn't really accomplish much after that. But for some of them, it seemed like that they were able to adopt some mutual protocols that helped both the transport staff and the emergency department to at least have a better expectation. What are we going to do when we arrive and the hotel is full, so to speak? So
So we have a EMS Medical Advisory Board that meets quarterly. Our next meeting is the 25th of May, and we've had that in place since 2006, I believe, since I put that in place. And that's been a consistent meeting where we've had attendance with CEOs, chief medical officers, EMS liaisons from both facilities, both fire rescue from Marion County and Ocala Fire Rescue. And it's been an advocacy and also a coordination of care that has existed for quite a period of time.
Well, I understand that, Doctor, but my question is, when the paramedic gets to the ED and he's been waiting there for 2 hours already, does he know what your advisory board has decided?
Certainly,
Or is he
they're a patient of that hospital, and the care is driven by that hospital at that point. And so if there's questions from that paramedic onto where it go with care next, they talk with one of the physicians or one of the advanced care practitioners that are in that facility for those orders. Because my protocols don't extend once they're into the hospital. Once they're within 250 yards of the hospital, they are the hospital's patient, right? And so my protocols that I write for EMS extend up until that point, and that's when that transition of care occurs. And that's some of the issues that you all are talking about is that, hey, it's the hospital's problem. It's no longer fire rescue's problem once that patient is on property. It's how to safely do that and hand off and transition that care. So even when Ocala or Monroe is holding that patient and somebody that comes in with chest pain, they remain on Marion County Fire Monitor at that point. But if the paramedic recognizes that there's something different going on with that patient, that paramedic is speaking to the charge nurse and then also the physician that's in charge at that time, so they can coordinate that care. Not that the care stops at that point, right? And protocols are driven through the common emergency management kind of issues. It's not necessarily just protocol driven, but there's a physician in charge there that takes that responsibility for those patients.
And Dr. Fromfelter, I think you hit the nail on the head, which is, something that's been the whole issue, is that once we get to the hospital or within 250 feet, those patients are no longer our responsibility. And so, that's why we've asked for some of the things to be put in place that we've asked for. Also, can you make sure that your EMS Medical Advisory Board meeting gets put on my calendar?
Certainly.
Thank you. Commissioner Arnett.
You had made a statement a moment ago about something about 2 hours, implementing a 2-hour time frame now, or possibly soon?
Well, no, what the hospitals had asked for was a little bit of leniency on the policy that we had looked at in implementing on when we would start charging them. Because we wanted to start charging after 20 minutes?
Right.
30 minutes, sorry. We wanted to start charging after 30 minutes. They felt like, basically what they're saying to us is, look, there's no way we can accomplish this because of the systemic issues, and that's not not anything negative to say to you, just because of the issues that are in place. Monroe's was staffing, Ocala Regional's is capacity, and these are not just local issues, they're local, state, national issues. And so they had said, can you make it a 2-hour time frame if we were to put the ordinance in place? And while I'm not quite sure that I'm comfortable with that long of a wait, I did feel like I did want to have a discussion with our board if we decided to implement that. But it sounds like right now what we're going to do is we're going to hold off, and then we will.
I don't think we've made that decision. My question is the hospitals, we're incurring the expenses now. We're paying it out of the county budget. At this point, is it reasonable to expect that the hospital should pay at least, if we did it at 2 hours? You're telling me we have 6-hour delays, so we're paying for 6 hours. Isn't it reasonable now that you pay for that additional 4 hours at least?
I'll respond first. I won't get into a discussion on whether it's reasonable or not, Commissioner Arnett, but what I would ask, if we're going to continue talking about potential options, then one of the options that we've talked about in the separate work group when we've met with Chairman Bryant is a third-party company to provide additional advanced life support transports when we get to the point in this county where our EMS trucks are in such a situation that they can't handle the volumes or stuck on a hospital wall somewhere, and we're trying to deal with that. So I'm not going to argue with you whether we should be at 2 hours, whether it's 30 minutes, whether it's 45 minutes. We can look at that, and we haven't looked at to see what would make the most sense as an entity for all of us, since this is an issue for all of us. It's just most glaring because it's an EMS issue on the public view. But we're working towards solving this. I can tell you at Ocala Health, except for the months of March and April, if I look at all of my wall times, my average is anywhere from 14 minutes to 22 minutes on average for all of my wall times. So that means I've got a lot that's way less than 15 minutes, and we have several, unfortunately, that are longer than an hour, but the average is somewhere between 14 and 22 minutes. So if we want to go down the path of an ordinance, I think we have a good bit of work left to do together collectively to decide what that ordinance would look like before we put something in place to charge the hospitals.
I couldn't agree more with Randy.
1 second.
I've been in 4 different states in my 38 years. There's been private, public partnerships in EMS because I don't care if it's Pennsylvania, Missouri, Illinois, or Florida, we all face these issues because you can't predict when that emergency is going to occur. And it's very, very difficult. I think we're doing our part now to reduce this. You know, we're down at Monroe to 29 minutes now. It's still 9 minutes longer than what we want, but we've made dramatic improvements by improving the staffing side and changing some of the processes. And I think I was the one that said 2 hours initially because, you know, if it's 2 hours, we own that. And it is keeping the EMS out of the field. But I think to say 30 minutes or an hour, we're in this together, working together, and I just think it's unrealistic to set those expectations and be charging the hospital that, again, is going to, as a taxpayer, both of us are, personally and professionally, we're taxpayers. I think that's putting another financial burden on a hospital industry that's seeing declining reimbursement. And pretty soon, you have to start cutting real services to pay for those things.
It seems to, excuse me, it seems to me that rather than wait until November, when we have a real problem, is that, you know, look at it, if not now, in July or August, and make that decision rather than waiting until the end of the year when we're deep in, I realize you're solving a lot of the problems now. Hopefully, unrealistically, we'd solve them all, which that won't happen. But we can start solving a lot of them between now and then. But I think we need to have, at some point in time, we need to put something in place so that, you know, because it's just, and I don't know who can tell me exactly the dollar is, but there's a lot of money that it's costing, not even considering the loss of life because they're not available.
Well, and I think that's why, you know, Commissioner McLean and I just kind of agreed on letting me continue to meet with our work group over the next several months and see what is going to take place with what we've implemented. And I think we all agree that the end goal is to try to not be, I mean, while we know that we're gonna have another hard season, but to try to not have the season that we had this last season. That's the end goal. And I think that as Commissioner McLean stated, by not getting on I think we will accomplish more and accomplish it quicker by not getting on an adversarial, by not getting in an adversarial place. So, you know, we need to take the opportunity to work together on this. Commissioner Moore.
I just want to thank both hospitals, all the hospitals, for making a concerted effort to improve. And I'm going to agree with both of y'all that we need to give some time to see how these improvements work. Because if this solves the problem, there's no sense of, you know, there's the old carrot, you know, before the horse, or you switch the horse in the back, you know, thing. Well, there's no sense of bringing out a switch if we're going to solve the problem. So, and the other side is free market. If we do anything that tanks either hospital, then we're going to really have some major capacity issues. So I'd much rather have, like Commissioner Bryant, meet with them, you know, work with it, try and make sure we solve the issues and go forward and be proactive instead of this, where this is kind of, okay, it worked in Alachua, but maybe they got to the point where that's all they had. We have other things. We have hospitals that are actually trying to correct the problem. Let's work with them to correct the situation and not, you know, sit there and penalize them. But now, if they were just basically saying, hey, we don't care, then I would say, okay, yeah, a penalty to force them to care. But if they already care, which they do, they care just like we do about saving lives. They're just, you know, caring like we do. So So why don't we work with them? And, you know, I agree, our chair should, as long as you're willing, sit down with them and try and, you know, I hate obligating somebody else to do work, but, you know, but sit down and make sure that we do the proactive steps
She
that
enjoys
solve
it.
the problems. Well, you know, and if we can solve the problems, let's solve the problems now and not have to go to anything like this ordinance. But then, you know, last resort, if nothing else worked, or if, say, you know, all the CEOs left and new CEOs came in and they didn't care, then maybe we would go to more of a thing. But, you know, I'm gonna have to agree with Commissioner Bryant, Commissioner McLean, that, you know, let's do the things together and work together as a team and make a concerted effort to solve the problem, instead of sitting there, you know, we don't wanna beat our hospitals up, because you and I know that we're someday gonna be a patient of one of those two hospitals. Kind of good idea to have them happy. Just say, when you need the extra pillow when you're in there, you might wanna keep them happy with you.
Commissioner Moore will always take good care of you at either side of First Avenue.
We'll have a
what you
pillow
say.
for you.
You'll have a pillow for me, but I don't want it over my face.
That's right.
You know?
So we're gonna set a time to
Sorry, I
have
got worse
another-
sense of humor.
Another discussion in 3 months?
So know what I'll do is I'll be meeting with them every month, and so at our board meeting, probably our second board meeting of each month, we'll bring forth the numbers. We'll I will update the board on the progress we're making, and then any additional plans that we're making to address, you know, what we're going to have to address come the fall, so that we don't run into that, and we'll just go from there. Okay,
Madam Chair,
Commissioner
I
McLean.
guess one of the things that I was hoping that you all would do too is, so I mean, the ordinance is written. It's
Great.
done
there.
pretty much, from the verbiage is done. I think the issue is maybe for you all to have a discussion about whether
Time.
it's 2 hours or 30 minutes, and maybe try to come to some agreement on that.
Right.
That way, if we did have to do this, then all that's worked out, everybody's agreed to it, and we can move forward from there. I guess I was hoping you'd do that. Commissioners, I think, again, I think we would be better to try to systematically look at the system and try to fix it. We can find both of these guys, we can find them $1 million or $2 million or whatever the number is, we can do that. Put it into our EMS fund, and certainly makes up for lost money or whatever, if you want to put it that way. But it doesn't systemically help either one of them. So I don't know, just some quick math, $1 million, I'm assuming you could probably hire 14 or 15 RNs for that kind of money. More? Okay, so.
Build a nice facility.
So my point is you could actually hire some bodies with that money, and I think that's the more important issue here, is getting bodies, not necessarily finding folks
Right.
for not being able to do something. And so that's why I'm willing to try and figure out how we can work on this thing over a period of time. I mean, it'd be, you know, same thing for us. We could go out and say, well, we got all these folks sitting over here, so we'll just go hire some more people. Well, that doesn't necessarily fix, I think, the problem that we're trying to fix. And so it sounds like y'all have made some good first strides here. I think if you'll commit to doing that, and y'all have a meeting, then, you know, again, you know, have everything ironed out, it's ready to go. I thought we're gonna get a report once a month, the commissioners will, and if there's issues with it, then we can have a discussion about it, and obviously you can report that back to the folks when you guys have your meetings and whatnot, so
Sounds good.
that's what I was thinking.
Sounds good. All right. We have direction from the board. Everybody knows what's going to happen. And so unless anybody else has anything else to add,
I got a question, please.
sure.
As far as and Dr. Fraunfelter mentioned the Timber Ridge, or one of us mentioned the Timber Ridge facility, as far as taking ambulatory patients in and that alleviating the hospital beds. I'm curious as to what percentage of people go into Timber Ridge and still end up transporting to one of the main hospitals, and also, along with that, what is the prediction as far as the potential from transport from the standalone facility in the South Marion area? We have a lot of firefighters, paramedics that are very concerned about that being opened, and that's gonna be another stop for us to be running ambulances back and forth to.
Oh, you wanna?
Well, I
Chief,
guess from Timber Ridge standpoint, it actually is a freestanding ED, as you well know. But we have a very low percentage of admissions from there. But I think as we see that end of the county growing with On Top of the World, with Bridgewater Park and the nursing home that's going out there, we're gonna see more and more. But we run about 7% admissions out there compared to closer to 13% at the main campus. So it's a lower number that comes from there.
Okay.
So there's more treat and street.
And that's for HCA, it's, Chief, that's actually a very good question, obviously something we looked at. We made an assumption that we would have below 5% of admissions coming out of our freestanding in Summerfield when we put together the financials for that analytical review. And what we're seeing across the state of Florida at the other HCA freestanding sites is it's that or less than that. What the other sites within HCA are seeing is quickly the crews determine, as they do today, if someone's truly going to be in an acute, needing acute services, they go ahead and take them to the hospital. They don't take them to a freestanding. And so that's usually what occurs, at least within HCA system in other parts of the state.
Okay,
Thank you.
thank you. Anything else? All right, seeing nothing, we'll be adjourned. Thank you all for joining us today. Really appreciate it. Yes, I do. I actually have something I want to talk to you about.